At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I am so proud to be able to bring you this episode today as part of Viral Hepatitis Awareness Month. So who better to both give us anchors and wings in our how we understand viral hepatitis and what we need to do about it than Dr. Robert Gish, who has been a friend to us all, whether we are a patient advocate, a patient, a researcher, a clinician, though based in the United States. His work and his influence is global. So welcome, Bob Gish.
Thank you, Donna. Fantastic to be here with you. And yes, let's try to cover the globe and cover the alphabet.
Fantastic. Let's start with the alphabet. I think to give people the foundations in viral hepatitis, they need to understand a few things. What are those?
Well, we have to think about the alphabet, as you said. And we think everybody needs to know their ABCs. And I think it's a global message because most people are learning English. So everybody has a different alphabet around the world, but be sensitive to that. But it's not just know your ABCs, it's know your ABCDEs. So the alphabet of viral hepatitis is a little bit longer, and we can go into each letter briefly if you would like.
I would love that. And I think understanding which ones are more likely to lead to chronic disease and which ones are less likely to would be helpful for people, I think.
Great. And we can make it simple. Hepatitis A is for acute, and it is vaccine preventable, and it's transmitted by contaminated food and water and never results in chronic disease. Super simple. B is for bad. This is because there's 257 million people who are chronically infected with hepatitis B today. B is for bad because right now we don't have a cure, but we can suppress and control hepatitis B in infected individuals. And we'll go into that deeper later, I'm sure. But think about hepatitis B as vaccine preventable. The vaccine's basically 100% perfect. And by vaccinating over the next 60 to 70 years, we can result in elimination of hepatitis B. And the final B message, at least for the short part, is get tested and get the triple panel and work with a provider who knows how to interpret that triple panel, which we can dig into a bit later. C is for chronic, just like B, but C has a cure. Get tested, get treated if you have confirmation of active hepatitis C infection. There is no vaccine for C, so occasionally people need to be retreated. But that's okay too, because each treatment has about a 98% cure rate. These medicines are very safe, they're short term, and just really minimal side effects. So these are really miracles of modern medicine today. Delta hepatitis, hepatitis D virus, HDV, is for deadly. This piggybacks on hepatitis B. You can only have Delta if that person is chronically infected with hepatitis B, meaning B surface antigen positive. But there are new treatments coming for Delta. There is a treatment already in Europe with over 2,000 people on this medication. It is a daily medication, but also very safe. And if you vaccinate for B, you can prevent D, you can prevent Delta. Super important. So other messages on D, we test everybody now who has hepatitis B for Delta. We can go into that a little bit more later if you would like, but there is a very accurate test available in many countries, not everywhere, but many countries. And let's wrap up with E. E for enteric. Enteric is our medical word for intestinal, again, contaminated food, contaminated water. E is rare in the United States. but many developing countries have hepatitis E on cycles of severity, such as India and Bangladesh. E is also vaccine preventable, but the vaccine for E, even though good, is only available in a few parts of the world just because of all the regulatory challenges of getting vaccines through WHO, FDA. That's the alphabet, A through.
That's a good portion of it. Virologists have been very active in identifying different types of viral hepatitis, and so yay to them. Thank you for that research and that wonderful articulation of them. I want to circle back to C because we have a cure in this. In your description, you gave both many challenges but also many opportunities, and I think we have an incredible opportunity in 2024 with several things going on. Dr. Francis Collins really serving as a catalyst and leading efforts to restart delivery to communities of the hepatitis C cure, and many generous donors. Recent announcements from some private as well as public dollars going to support global programs towards elimination of hepatitis C. And so tell us about this bright light in viral hepatitis, the opportunity to eliminate hepatitis C.
Some things are bottom up, some things are top down. Now we have a method to meet in the middle. We have all these great advocates, GLI, we've got NVHR, we have all sorts of other hepatitis C advocates on local, regional, and national basis. And of course, there's this WHO and this CDC elimination, but you can't get there without having both the advocacy, the great medications, but also having a policy in place that harmonizes across what we have in our wonderful country, a very dysfunctional healthcare system. So you can go to Egypt, you can go to Iceland, you can go to the country of Georgia. They're on track to eliminate this virus. And I'm leaving out many other countries that are going to eliminate C by 2030. We're out 2050 without a government investment. But when they did the modeling for a cost of about $11 billion over 5 years, they're going to save $25 billion.
Can that modeling be sent over to the CBO? Because I think that I hear rumors that that's what we're waiting for in the US. And so if there's a way to accelerate that process, I would certainly want to be a part of that.
Absolutely. I can't remember. I know the CBO is looking at this, and I just saw that news release yesterday. But there's also modeling, and Homi Razavi with the CDA and the Polaris may have that available. But let's communicate.
Excellent. And since I'm a little closer to the hill than most people, I'm happy. I'm there frequently and happy to deliver some news because we need to get this done. I think that's we had this opportunity. I remember at the very start of GLI, we're celebrating our 10th anniversary and when the cures were just launched. And here we now, 10 years later, and still about half of the people who are eligible at minimum are not treated. So I'd love to be able to check that off and fix that during my anniversary year. Here.
We know you have been a key catalyst in that, Donna, with the GLI. So thank you for your work.
Absolutely. Thank you. Always supporting, creating opportunities for us, letting us know really what the problem is so we can be smart about a solution. And so that our advocacy is as effective as possible. So I thank you for that because you've done that in so many different opportunities over the years. So B is something that may be feeling a little bit left out with the conversations around hepatitis C or the electrifying news of approval in NASH, but we who believe, pun intended, that the hepatitis B is as important, can have a really great movement in 2024 to what would that take? What would that look like? We already have a vaccine that's getting to most people. We're filling in those gaps, but what's needed to bring hepatitis C the rest of the way?
So the hepatitis B world has had some
This B word.
beautiful events over the last 2 years. The first thing, of course, was the ACIP said vaccinate every adult. It had a couple
Right.
minor twists in there about age 59, which I think is irrelevant. But
Yes.
before you vaccinate, the CDC had to harmonize and say test all adults. The
Hmm.
CDC delivered that package. And I want to, for a moment, talk about the 3 tests, Donna, in
Yes.
hepatitis B.
Please.
So, hepatitis B, to test all adults for hepatitis B is to order a triple panel, and that includes 3 simple tests: surface antigen, it's hepatitis B surface antigen; core antibody, the total antibody to hepatitis B core; and surface antibody.
Mhm.
So, 3 tests. The interpretation gets a tiny bit complicated because sometimes 2 tests are positive, but surface antigen means infection, get linked to care.
And I know how easy it is because I had to get retested to be able to, I was taken off of my IBD biologics to have surgery. And several months later, we're considering putting me back on. And so restarting the whole, clearing and preparation set of steps. And part of that is rightly hepatitis B testing, less going on a biologic or any other type of immunosuppressant. If I had hepatitis B and it would be reactivated, that would just, be unnecessarily, traumatic, and in some cases, deadly. And so let's avoid that. And so it was, very easy to get tested. So I want that message to go out to patients as well, that they hear the doctor's description, but as somebody who has, the patient experiencing it, it's not, doesn't take a lot of time. It's not going to be delaying your treatments for other things, and it's a really important step not to miss.
And you brought up a key word to discuss the next test, and that's core antibody. A person who has hepatitis B core antibody total
Mhm.
indicates they've been infected and they still have residual virus in their body right now, forever,
Mhm.
because B is incurable. So once
Right.
you've had B, you always have a little bit left, like
Mhm.
Epstein-Barr, mono,
Mhm.
CMV. So this core antibody test indicates a patient needs to be educated about the risk of reactivation, just like we would with surface antigen. So core antibody is essential. That was modeling done by Malika Toy and Sam So through the Asian Liver Center at Stanford. Critical paper for getting the
Mhm.
CDC to move, getting ACIP to move. Their research was fantastic. It was cost effective to do the triple pan
Mhm.
because core antibody, if positive, means no vaccine. Had the virus, vaccine's not going to be of any use.
Right.
That saves a lot of money. So core antibody led to a lot of confusion, but now we are clear. It's now for clear, core for clear, and
Mhm.
that's what core means. And finally, surface antibody, third part of the triple, indicates immunity if core is negative.
Mhm.
So triple panel, people are triple negative, vaccine. Nobody else needs vaccine. Saves lots of anguish, concern, time, money. To be clear on the 3 tests. Is that simple enough, Donna?
I think it is, and I'll let our viewers and commenters let us know if it isn't. We might even take a poll on that. I do know that this audience, the DLI audience, finds affection in terms like portal hypertension. That was like the buzzword of A3 a few years ago, and so you never know what's gonna hit, what's penetrating. It's just creates these aha moments for people that thought things were hard, but now you have clarified them for them, and then you just carry them. Well, you don't carry them around. Hopefully, you know them. You know them for the rest of your life, and it's really important for liver advocates, no matter what path they take in, to understand all these different areas of liver disease and liver health. So no matter where they are, they can speak to it. They might be able to, um, clarify or stop some misinformation from being shed. And it could be just that simple and make such a difference in someone's life. Having heard this, finally understood how the 3 different tests work together, and being able to explain that to a church member or someone else at a community meeting. So I thank you. I thank you for that.
Can I put a little plug in for the Hepatitis B Foundation?
Please.
All right. The global leader in hepatitis B information is Hepatitis B Foundation, advocacy, research, policy. They have a patient interface with about 11,000 patient or advocate contacts every year by email, fax, phone. They're just a fantastic resource and have been a foundation, a incredible pillar for global hepatitis B education and elimination.
Here. I was smiling earlier when you mentioned Dr. Sammy So's name, because one of my first jobs when I got to a PR firm was to prepare his awards packet when he had won an award for his Jade Ribbon program on hepatitis B. And so that was to start with something I was so proud to be able to do. And that was my first introduction to the hepatitis B community. And then I learned about the Hep B Foundation and was able to, direct support in that towards that foundation and that work. And so it has been a model to me as I've built GLI, and we are the better for having that foundation. So I'm excited. Thank you. I'm happy to give you that time for the Hep B Foundation and my friends over there.
Great. Can I make one more comment about hepatitis B? That
absolutely.
I call it misinformation.
Yes.
When providers are talking to patients,
Mm-hmm.
they're telling people they need to be on treatment forever. That's such a negative message to patients and family members, advocates, because we have over 30 new medications in development for hepatitis B. One whole package just got fast tracked through the FDA for one of our phase 3 drug development plans. So we've got just incredible, and to list one company, I'd have to list all 30 or 45.
But I think 30 points to the excitement that we have in research now in hepatology, which we didn't. I think success breeds success, and we've really created, not only through the success of the science, but also the maturation of the advocacy in now having a really diverse and robust pipeline in most forms of liver disease. And I think our focus on taking notes from the AIDS community in having some of our fields really devote a lot of time to regulatory advocacy and understanding has stood us in good stead. And we're seeing the fruits of that now with so much hepatitis B drug development. But please say more.
So another, I think, important issue that just changed 3 weeks ago in Japan at APASL was the WHO coming out with their new global guidelines for hepatitis B. And this had to do with who to test, what to test with, and then who to link to treatment. As you know, less than 15% of people who should be on hepatitis B treatment today are being treated because the guidelines are incredibly complicated. And they're typically written by hepatologists. If infectious disease people were writing this, everybody can get treated. We got there with hepatitis C, finally. But hepatitis B, we're still pulling that stone or pushing the stone like Sisyphus, up the hill. The Chinese guidelines came out in 2022 in Chinese, so I didn't read them at the time. But last year, 2023, they translated them into English. And I'm going to summarize the Chinese guidelines as the best in the world. And they said, treat everybody who's DNA positive. WHO didn't quite make the jump. So if you look at what the Chinese are doing, you're going to treat 90 to 95% of people. WHO, more complicated about fibrosis and maybe ALT and DNA over 2000. That's going to only move treatment up to 60 or 70%. I'm going to compliment them. They made a big jump, but they didn't jump all the way to the door. And to jump to the door, we need to treat hepatitis B as an infectious disease,
Right.
treat it as prevention, stigma, quality of life, extrahepatic disease, including other cancers. That's 2 points. And when you treat hepatitis B, you reduce liver cancer risk by 70%, and you
Right.
reduce the risk of cirrhosis and transplant and death by 90 or 95%, as long as people don't have alcohol or fatty liver or something
Right.
else going on. So this
Well,
new package, we're making progress, Donna.
there are a couple of threads that I wanted to tie together in what you have said. One is the importance of the growth of diagnostics or testing along with treatment, because you can have the greatest treatment in the world, but if people aren't getting diagnosed, if there's not a simple, understandable, scalable testing regimen that's available, people won't get treated. And we see that in viral hepatitis, but we see that also in NASH. We see that in other liver diseases and other diseases. And so I think that's very important for people to think about as they're designing, care pathways and health systems and programs to really get people access. There needs to be both an attention to the diagnostic and the testing components, as well as to the treatment.
Can I comment on the testing story?
Please.
Fantastic point. We don't have any rapid tests for B in the US. There are some in Asia that look to be good quality. And the FDA, in their insightfulness and their response to pressure, to education, is moving, I hope, this isn't final, but they're moving hepatitis B from what's called class 3 to class 2. And they're talking about moving many infectious diseases from class 3 to class 2. And you'd say, wow, what does class 3-2 mean? All right, very simple. Class 3, 5 million, 10 million, 20 million to get a test approved. Class 2, probably logarithmically less, about tenfold less cost. So application and the research is simpler, but I don't think there's any compromise in quality. I think the FDA's emphasized that too. But you've got to make things class 2 to let people invest in rapid tests, for example, because tests are cheap. Everybody's putting pressure. Make the test cheap. Make the drug cheap. Well,
right.
You don't make
It
everything.
it also allows for community organizations to be able, or prisons, or just other different settings to be able to deliver to conduct testing as part of their activities, and that helps reach the hard to reach. And so if we're going to make sure that there is equitable access to vaccines, to treatments, to whatever it is that we're talking about, we need to pay attention to each part of that being equitable and facilitating access, and being able to be used by a community-based group of maybe non-professionals with an NP or a physician sort of looking over, is allows for many more people than a test that needs to be administered in a hospital or an academic setting. I point this way to hospitals because I have a hospital just a few blocks behind me, and so it makes a big difference in the goals that we can set with different programs and what we can achieve if each piece is thought through in that way.
And Donna, you mentioned nurse practitioners, and I'll put them under that APP umbrella with PAs also, and pharmacists. What's your opinion about pharmacists getting involved in testing and linkage to care?
I think it's so important, and that's not just because my uncle taught pharmacy at Howard University, but because I've also seen my parents' experience in how close they were to their community pharmacist and the trust that was there, and the opportunity that's there, that's being created by so many different corporate and other entities to bring care closer to where people already are. And so I think pharmacists have an incredible opportunity for all the people that they touch to be able to play a large role in this.
Fantastic. Totally agree.
Yes. So my dearly departed mother, it was one of her favorite sayings was, "Common sense must prevail." Um, and it was well known, apparently so well known, that the entire groups could chant it. And as Dr. Henry would say, common sense must prevail. And so I think that if we use that as a rubric for how we think about delivering these treatments to all the people who need them in the most, cost effective and efficient manner for all sides, for the clinicians and the systems who are trying to provide things, and to the people who need them, but this is the only thing that they need in their lives. Then common sense solutions that enable things to be delivered in the context of people's lives, I think will tend to be the most successful. And so we need to do that in sort of all our viral hepatitis work. And I think making, multiple viral hepatitis testing and treatment available under, one umbrella. People know that my aspiration is for, health hubs to be in places all over the world. Even we've talked to some some innovators who are looking at things that can be solar driven and have healthy foods on one side and vaccines and medicines on the other side that can reside in rural villages in different countries that I know that you work and that we have partners. And I think it's that type of thinking rather than the silos, I think, that have kept us apart and only marginally successful, that will really bring this all home.
Great summary. That is fantastic. Did we leave anything else out of the ABCDE world? I'm trying to think if we've missed any major comments. Well, one good thing is AASLD is rewriting their guidelines for hepatitis B, and EASL is rewriting their guidelines for hepatitis B, and I'm hoping APASL, that's the Asia Pacific, rewrites those, and they harmonize these and make it simple and not have conflicting statements. Oh, we have to customize it for different parts of the world. Well, that's true, but in many countries, testing is more expensive than treating.
Right. One of the ways that we can achieve that harmonization, I have found, is by having patients on those guidelines committees. I've served on three different specialties so far, and talking to patients and community advocates who have also been on guidelines committees. We have a more practical, I think, view of things. We still read the science, and we still defer to the doctors when necessary, but we ask different questions about what perhaps is necessary, and have a slightly more practical goals. And so that's one thing that I would hope, and that we are able to equip advocates in many countries who speak many languages to participate in those processes, so that the guidelines do harmonize and the guidelines do meet the needs of the people in communities who need these treatments the most.
Great point. And we have to recognize that the guidelines often are out of date. Our hepatitis B guidelines today, the ASLD, are 10 years out of date. Most of the data in the guidelines was before 2015.
Right.
So they need to redo these in real time, not wait 10 years.
Dr. Gish, what do you practice in a lot of different settings, and so what do you see actually happening, with guidelines that are of that vintage, when we know that there's more recent evidence? Is there the opportunity to sort of curate sort of best in class evidence packages that doctors can use to support treatments that they want to be able to provide their patients, that may be out of sync with the guidelines, but are definitely in sync with the best practice and current evidence?
It is a challenge because you will find some providers are paralyzed by the guidelines. They cannot make a move without the guidelines being rewritten. and that needs to change.
Mhm.
Some of these are academicians who, I'm going to say something negative here. Everything's been positive today. People keep saying,
Okay.
well, they need more research because they need more funding, they need more papers, they need academic advancement. But where is the patient in that we need more research
Mhm.
package? So they leave
Right.
that stigma, quality of
Mhm.
life, activity out of the big picture. Why did it take us 50 years to get patients on guideline committees? We are
I could tell you, but that would be another show. Dr. Gish, it has been a joy. I've learned so much, and I know our audience has. Be well. Thank you so much.
Thanks for having me.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.